Good morning, everybody. Welcome everyone to today's webinar on the American Diabetes Association Standards of Care in Diabetes 2023. Today's webinar is brought to you by No Diabetes by Heart, a joint initiative of the American Heart Association and the American Diabetes Association. The purpose of today's webinar is to highlight important updates to this year's standards of care and how these changes impact clinical care, especially as they relate to type 2 diabetes, cardiovascular disease, and chronic kidney disease. My name is Alex Chang. I'll be moderating today's session. I'm a practicing staff nephrologist in the Department of Nephrology and an associate professor of clinical research in the Department of Population Health Sciences and co-director of our Center of Kidney Health Research at Geisinger Health in Danville, Pennsylvania. Before we begin, we would like to recognize the No Diabetes by Heart founding sponsor, Novo Nordisk, along with the national sponsor, Bayer. Thank you for your support. We invite you to visit the No Diabetes by Heart website, nodiabetesbyheart.org, for downloadable materials that will support you in your practice, guideline information, case studies, and a library of our earlier webinars and podcasts. We'll be hosting a Q&A session at the end of today's presentation. There's going to be a lot of great details packed in here, and please use the feature of the Q&A to submit any questions. We'll try to answer as many as possible. Listed on the slide are the faculty disclosures. And it's my pleasure to welcome our esteemed expert to today's webinar. We're joined by Dr. Dennis Breumer, staff cardiologist, director of the Center of Cardiometabolic Health, professor of medicine at Cleveland Clinic, Lerner School of Medicine, Case Western Reserve Medical School. Dr. Breumer specializes in preventive cardiology. He has a special interest in cardiac intensive care, echocardiography, and is board certified in internal medicine, endocrinology, cardiovascular disease, and echocardiography.
All right, thank you very much, Dr. Chang, for hosting this and for inviting me to participate. Again, thank you very much for the American Diabetes Association and American Heart Association, our sponsors, for organizing this. I think this is a very important section. We will be discussing section 10 out of the standards of care of the American Diabetes Association treatment guidelines, focusing on cardiovascular disease risk management. And then Dr. Chang will be outlining changes in section 11, the CKD section. So we have a very tight program, and what we will do is we will go over some of the key changes that were made in the guidelines. We will go over changes in the hypertension management. We will discuss lipid management and the benefit of some of the drugs that we use for cardiovascular event reduction. Now, I want you to remember these 4 key components of treatment, because when you see patients, it is really the comprehensive management of these patients that drives home the cardiovascular benefit that we wish to aim for. So with that in mind, I'll have Dr. Chang briefly go over the changes in hypertension management, and then I'll go over some of the lipid management. So Alex, Dr. Chang, please take it away from here.
Wonderful. Thank you, Dr. Breumer. Yes, so one of the major changes is really aligning the ADA blood pressure hypertension definition alongside the American Heart Association. So the guidelines now says that hypertension is defined as a systolic blood pressure greater than or equal to 130 or diastolic greater than or equal to 80 based off average of 2 measurements obtained on more than equal to 2 occasions. And, I think that this is a very important thing to do, try to align guidelines, as they can get a little bit confusing, and the evidence is supportive and is well outlined in this document. If the blood pressure is greater than equal to 180 over 110, you could diagnose it with that one visit, and you can see the level of evidence there is in E. As the important thing is highlighted in the next point is that if you have a patient with hypertension diabetes, you really should also monitor their blood pressure at home, because white coat effect also masked hypertension, where blood pressure is actually higher at home than at the doctor's office, is very common. And so we should monitor for those things as we're going to be trying to control blood pressure more intensively. For patients with diabetes and hypertension, the blood pressure targets really should be individualized, just like everything we do in medicine. There should be a shared decision-making process that addresses the cardiovascular risk, potential adverse effects of the antihypertensives, and taking into account the patient preferences and, of course, where the patient is in terms of all their other management. People with diabetes and hypertension, now it says qualify for antihypertensive drug therapy when the blood pressure is persistently greater than or equal to 130/80. Again, really making sure that that threshold is well defined at 130/80. The evidence behind that, you can see it's a grade B evidence, and there has been some controversy in the past over the blood pressure targets in diabetes. We won't go exhaustively through the different blood pressure trials, but a quick, if you overview of all of the blood pressure trial data is essentially that, more tighter control in patients with diabetes should reduce risk of particularly stroke risk and albuminuria. And so if you look at ACCORD, which is sort of the landmark diabetes trial, there was some signal for stroke. If you look over at the event rate, there is a thought that it was probably underpowered actually. And so if you look at meta-analyses combining a lot of different trial data, they all seem to suggest that a lower blood pressure target would be beneficial. There weren't any diabetes patients in SPRINT, of course, but the SPRINT was very similar to ACCORD in the trial design. The important thing to know from both SPRINT and ACCORD is that, the benefit of the cardiovascular primary composite outcome for SPRINT, both trials, there are some risks of intensive treatment as well, and these were targeting a systolic blood pressure less than 120. So the main thing there is, of course, some higher risk of electrolyte abnormalities, acute kidney injury, and hypotension. And those are things that, again, you're going to really want to make sure that we're emphasizing the home blood pressure monitoring more as we're aiming for lower targets to reduce cardiovascular risk. 10.9 says treatment for hypertension should include drug classes demonstrated to reduce cardiovascular events in patients with diabetes. The ACEs and ARBs are still recommended first line for patients with hypertension and diabetes and coronary artery disease. There's a little bit more nuance there covered in the CKD section a little bit later. And I'm going to hand it back over to Dr. Breumer to tackle all the lipid management changes.
All right, thank you very much, Dr. Chen. So the changes in lipid management that were included this year in the standards of care were really meant to make it a little bit easier and clear on how do we treat patients with diabetes. And I will briefly go over this, and we'll go over some of the evidence, just the key points. So we're talking about primary prevention. So these are patients now without atherosclerotic cardiovascular disease. High and moderate intensity statin therapy is recommended. And the LDL cholesterol goal for these patients, this is primary prevention, is less than 70. This is a change in the guidelines, and this is really because type 2 diabetes is a cardiovascular risk equivalent. The event rates are approximately similar between patients with previous history of coronary artery disease and patients who have type 2 diabetes and no history of coronary artery disease. Similarly, there are outcome trials. For example, the heart protection study, simvastatin, about 6,000 patients with diabetes were treated. And in this study, really, the reduction in event rates was quite evident, lowering the cholesterol, the LDL cholesterol from about 116 to 77 milligrams per deciliter in patients with diabetes, reduced macrovascular disease by about a quarter. Now, in addition, there are meta-analysis, the major meta-analysis to support tighter targets in patients with type 2 diabetes is the cholesterol treatment trialist collaboration. This really showed significant reductions in mortality and coronary artery disease. And this is in about 19% of the patients had a diagnosis of diabetes. And every 1 millimole per liter, that's about 39 milligram per deciliter LDL cholesterol reduction, was associated with a 25% risk reduction. And there really wasn't a bottom threshold seen in this analysis at which the reduction in LDL cholesterol would not derive further benefit for patients with diabetes. Now, for patients now who have evidence of atherosclerotic cardiovascular disease, so we're discussing secondary prevention. So those are the higher risk patients again with diabetes and overt cardiovascular disease. The LDL cholesterol goal is 55. So really the two numbers that you need to remember when you treat patients with diabetes is 70 for primary prevention, that's the LDL cholesterol goal, and 55, that's the LDL cholesterol for secondary prevention. Now, the majority of evidence comes from add-on therapy trials to statin therapy in patients with diabetes. This is the IMPROVE-IT trial data, which included simvastatin with ezetimibe. And you can see these are the patients who had a reduction in LDL from 65 to 46. And if you only focus on the red and orange line, the red line, those are the patients with diabetes on placebo and simvastatin. And in orange, you can see those patients with diabetes and ezetimibe combined with simvastatin. So the combination treatment and the lower LDL cholesterol basically drove most of the benefit in this combination trial with statin and ezetimibe. Similarly, in patients who are treated with statin plus a PCSK9 inhibitor, these are the trials, the Odyssey outcome trial and the Fourier trial. Keep in mind, a large number of patients in these PCSK9 inhibitor trials actually had diabetes, and the achieved LDL in both of these large trials was actually about 30 milligrams per deciliter. And what is important, that the absolute event reduction in patients with diabetes was almost twofold higher than in patients without diabetes. And the number needed to treat to prevent an event in patients with diabetes was about half that than in those patients without diabetes. So these are some of the key points and evidence as to why these guidelines were changed. And these guidelines are in line with other guidelines. ACC/AHA guidelines recommend to add ezetimibe in patients without high risk, but those patients who are at higher risk, including those with diabetes and have an LDL above 70, should be added a PCSK9 inhibitor. American Association of Clinical Endocrinology recommends an LDL cholesterol goal of less than 55 milligrams per deciliter in patients with diabetes and overt cardiovascular disease. So does the European Society of Cardiology. So we've sort of modified these guidelines, not just according to the evidence, but also along with other guidelines. So when we treat patients now with atherosclerotic cardiovascular disease and type 2 diabetes, this is some of the recommendations, the expert consensus decision pathway, which is also part of the guidelines. If you have a patient with type 2 diabetes and atherosclerotic cardiovascular disease, so we're moving away from lipids now to more the cardiovascular beneficial drugs, which are reduce event rates in patients with diabetes. We optimize guideline-directed medical therapy for prevention. This includes lifestyle, blood pressure, lipids, glucose, and antiplatelet therapy. But in addition, we recommend starting an SGLT2 inhibitor or GLP-1 receptor agonist with proven cardiovascular benefit. So the guidelines now, there's not much change in this particular aspect of the guidelines, but patients with type 2 diabetes and established atherosclerotic cardiovascular disease, multiple risk factors, or diabetic kidney disease, which Dr. Chang will discuss in a few minutes, are recommended to be added a sodium glucose cotransporter, an SGLT2 inhibitor with demonstrated cardiovascular benefit. In addition, patients with diabetes and established atherosclerotic cardiovascular disease, multiple risk factors should be considered for a GLP-1 receptor agonist. In fact, what we'll discuss in a second, that even we could combine an SGLT2 inhibitor and a GLP-1 receptor agonist. And I'll show some of the evidence when we go through our case here in a minute. Now, as you're all aware, the SGLT2 inhibitors have advanced to become one of the key treatment strategies for mortality reduction, hospitalization reduction in patients with heart failure with either preserved or reduced ejection fraction. So this is a key class of medications for a broad spectrum of patients with heart failure. Patients with type 2 diabetes and established heart failure, again, with either preserved or reduced ejection fraction, should be treated with an SGLT2 inhibitor, in addition, for the indication to improve symptoms, physical limitation, and quality of life. And in the guideline document, we discuss recent outcome studies over the past year that have supported this new indication to add the symptom control, physical limitation, and quality of life, which we feel is an important addition to the treatment recommendation. Now, patients with type 2 diabetes and chronic kidney disease with albuminuria, this is a topic that Dr. Chang will discuss, should be added a mineralocorticoid agonist, which again, Dr. Chang will go over in a couple minutes. So with that in mind, we will go over a case, and I encouraged you to participate in the audio response system. So this is a typical case that we see, for example, as cardiologists in our clinics. And we will go over some of the questions behind those, some of the evidence, and what are some of the interesting nuances about this case. So this is a 51-year-old gentleman who has class 1 obesity and presents to the emergency department with chest pain. So a very common scenario. He's maybe not really seen a physician over the past couple of years. He takes really no medication. He doesn't smoke, doesn't drink alcohol, has no additional risk factors in the family, has really no other markers, no premature coronary artery disease family, normal blood pressure, again, body mass index 33, class 1 obese, physical exam is unremarkable. So this patient gets an EKG, as recommended, of course, and you can see the cardiologist, internist, and endocrinologist. Everyone will recognize that this is atrial fibrillation. So the patient presents with new onset atrial fibrillation and rules in for acute coronary syndrome by high sensitive troponin testing. So he has chest pain, he has an elevated troponin, and he has atrial fibrillation. So this patient obviously gets treated. It's loaded with aspirin, loaded with clopidogrel, P2Y12 inhibitor treatment, gets put on heparin, metoprolol, and gets added a statin. And class 1 recommendation, lipid panel, hemoglobin A1C are tested. The LDL cholesterol in this patient is 145 milligrams per deciliter, and he has a hemoglobin A1C of 8.6%. So new onset or newly diagnosed diabetes, hypercholesterolemia, and acute coronary syndrome in this patient. So again, a very common scenario. So, and I'd like to invite you to participate in this question. So what percentage of patients with acute coronary syndrome would we expect to actually have newly diagnosed type 2 diabetes? So this is a scenario that the cardiologist encounters pretty frequently. So about 57% of the audience says it's about, this is 30% of the patients that we see in the emergency department presenting with acute coronary syndrome have newly diagnosed type 2 diabetes. And this is actually double the number that you would expect. It's about 70% of patients with an acute myocardial infarction have diabetes or prediabetes. This is coming out of the TRIUMPH registry, including almost 3,000 patients. And you can see prediabetes by A1C testing, type 2 diabetes. Type 2 diabetes is about 30%. We added in the prediabetes, which is actually not a benign diagnosis, because even having prediabetes doubles the risk for cardiovascular disease. So keep that in mind when you find those elevated hemoglobin A1Cs on your patients. Prediabetes is a clear risk factor for cardiovascular disease. Now, what is important to note, if we combine prediabetes and type 2 diabetes, that about 70% of patients with myocardial infarction, half of these patients are unaware. So this is a frequent diagnosis. So you could argue actually that the cardiologist makes a frequent new diagnosis of type 2 diabetes and then collaboratively has to work with primary care physician and endocrinology teams and educators to start to treat this patient. And this leads me kind of to the next question, which we will get to in a second. So this is the coronary angiogram. And you can see that this is the left main artery, and this is the circumflex artery and the left anterior descending artery. And you can see there's the plaque, and the right coronary artery has some minimal disease, but this patient gets appropriately treated, gets repaired here with a stent, chest pain is gone, and gets treated. So he also undergoes TEE-guided cardioversion to restore his sinus rhythm, because keep in mind, he was presented with atrial fibrillation. He is treated with dual antiplatelet therapy. He is started on oral anticoagulation. He's beta blocked, and since he presented with ACS, he's treated with ACE inhibitor and high intensity statin therapy. So now, keeping this in mind, the treatment that the patient received brings me to a question that sort of highlights, I think, where we are and where we, I think, need to do better. So how often is treatment for diabetes adjusted in patients with uncontrolled diabetes admitted with acute myocardial infarction? So would this be always 2/3, 1/3, never, or, well, just ask the endocrinologist? So again, test-taking strategies, probably the evidence is somewhere in the middle, so take your guess. I think it's important to remind us that we own the patient in the hospital setting, and this is where we can make key changes to the treatment, and this is where often treatment should be adjusted, because the adherence and follow-up and outcomes are actually better in those patients. So the about 1/3 of the time, I think that's outstanding. So we will look at this in the next slide. This is a little bit older data, but what I would like you to focus on is only this dark blue bar in the middle. So this is first the question you have to ask: if we adjust diabetes, how often do we actually know what the diabetes control is? So how often do we actually get a hemoglobin A1C in those patients admitted? That is frequently, I see this, not always tested. So if the hemoglobin A1C is tested in patients and it is between 7 to 9, which is about 1/3 of the patients admitted with ACS, you can see that in about 1/3 of the time, this is here, patients undergoing glucose therapy intensivation. So about only 1 out of 3 patients admitted, 1 out of 3 patients admitted with acute coronary syndrome and uncontrolled diabetes gets their treatment adjusted. So this is, I think, again, this is a scenario where we can do better and where we own the patients when we see them in the hospital, and we can make important not just changes, but we can also refer, we can consult, we can ask. So I think, again, this is an important area for improvement in care. Now, as I had mentioned, I had shown you this. So this is a patient with atherosclerotic cardiovascular disease, type 2 diabetes. We optimize guideline-directed medical therapy, and the patient now should be treated with one of the two classes of medications which have proven cardiovascular benefit. And the guidelines recommend to initiate treatment once the patient is stabilized. This is, I think, again, an important opportunity. So this patient, in addition to the medical therapy here, is added an SGLT2 inhibitor at the time of discharge. So the next question now, the patient comes to follow up to you into your office, and he feels well, no further chest pain. He tolerates all his medications. He's involved maybe in cardiac rehabilitation already. He changes his lifestyle. And he heard about metformin. And he said he heard from one of his buddies that, he's on metformin. And he asked, well, I heard metformin is a good drug for diabetes. So the question is, should he be started on metformin? So again, this is a very common treatment scenario. And I would like to ask your opinion whether this patient should be added metformin at this time. So 64% answered this question with yes. And we will go over, I think this is probably one of the more challenging questions in this case. And I will go over what is the evidence. Why would we add metformin in this patient? Now, metformin has been around for a long time. This is the 1998 subgroup that had been treated with metformin in the UK PDS trial. So 1,700 overweight patients with type 2 diabetes. 342 patients were treated with metformin. And this is the cardiovascular benefit that was seen with metformin in these overweight patients with type 2 diabetes. And you can actually see there was a reduction in all-cause mortality, significant. There was no significant benefit for myocardial infarction and no significant benefit for stroke. Now, this is the main cardiovascular outcome data we actually really have to support metformin. You can argue whether this is sufficient. It certainly would not hold FDA standard today to get an indication for cardiovascular event reduction. Now, so from this data, we would argue that today we have evidence actually for much better treatment. And one of the meta-analyses that included 6 trials using 4 different SGLT2 inhibitors, enrolling over 50,000 patients, in which metformin use was between 20% to 80%. So a fairly high number of patients with metformin use. SGLT2 inhibitors actually reduce the risk for cardiovascular events independent of whether a patient was treated with metformin or not. So based on that, you could argue that the SGLT2 inhibitor benefit might be independent of metformin use. And you could tell the patient, well, metformin is a drug that is sufficient for treatment of diabetes, lowers hemoglobin A1C, but we may actually have better choices that have proven benefit in a patient after an acute coronary syndrome, may even have benefit for his class 1 obesity, and maybe a better choice. So the patient monitors his blood glucose levels and has still a little bit of hyperglycemia, and you mentioned better choices, and his wife saw an ad and suggested, well, maybe the GLP-1 receptor agonist class would be a drug of choice for him. And this is the current pharmacology treatment recommendation in the standards of care from the American Diabetes Association. So you can see that in patients with diabetes, first, of course, again, lifestyle modification, you're very well aware of this now. This is the goal of treatment is really cardiorenal risk reduction in high-risk patients. So this is a patient with type 2 diabetes and high risk. He just had an acute coronary syndrome. So in patients with atherosclerotic cardiovascular disease, like this patient, you're encouraged to use an SGLT2 inhibitor with proven cardiovascular benefit. And if the patient remains hyperglycemic, we add actually now a GLP-1 receptor agonist, or if the patient had been started on a GLP-1 receptor agonist, we would now add an SGLT2 inhibitor. And this is independent of whether the patient is treated with metformin. So by this current treatment algorithm, we would recommend rather using a GLP-1 receptor agonist than actually adding metformin at this time. Some of the evidence has been shown in the Amplitude trial, which used the GLP-1 receptor agonist. Is currently not available in the United States for full disclosure, but this compared basically MACE and non-cardiovascular death in patients, whether stratified, whether the patient is treated with an SGLT2 inhibitor or not. So the GLP-1 receptor agonist seemed to occur independent as to whether the patient is treated with an SGLT2 inhibitor or not. So this encourages use of GLP-1 receptor agonists in this particular patient. So the patient is treated. I added a GLP-1 receptor agonist at this time. And I think this is one of the main messages. So you can, if you don't remember everything I say, I think this is really what we need to focus on. So what percentage of patients with diabetes meet guideline-directed treatment goals? And this is less than 20, more than 80, or somewhere in the middle. So again, what percentage of patients are currently treated according to treatment goals, meet treatment goals? And you all know how difficult it is to treat these patients and to get all risk factors controlled. So 44% less than 20, 47% less than 40. So the majority recognizes that it's very difficult to have treatment meet all guideline recommended treatment recommendations. This is a recent analysis published last year looking at 320,000 US patients with type 2 diabetes. And in these patients who had evidence of atherosclerotic cardiovascular disease, I'd like to point out that only 26% received high-intensity statin therapy. So again, keep in mind, all these patients should be on high-intensity statin therapy. 45% on ACE inhibitor, 3.9% on GLP-1 receptor agonist, 2.8% on received SGLT2 inhibitors. And I noted in the chat comments that there was a comment on formulary of payers. So this is certainly something to discuss, cost of these medications, but in overall, fewer than 1 in 20 patients are prescribed 3 evidence-based therapies. So this is really, I think that, we know about statins, we know about ACE inhibitors, we know about SGLT2 inhibitors, GLP-1 receptor agonists. I think we're getting better. If we factor in now the more stringent LDL cholesterol goals, the more stringent blood pressure goals, it'll get even more difficult, but it will also be even more important to treat these high-risk patients. So we'll close up here in a minute, but the patient returns a couple of weeks later, LDL cholesterol 63 milligrams per deciliter. So the question then comes, what is the next step in this patient for treatment? And again, you could say, well, is he at goal? We would just repeat the lipid panel, you consult nutrition, or you add a second lipid-lowering therapy using ezetimibe or PCSK9 inhibitor. So please take your questions. So yes, absolutely. About half the respondents said that add ezetimibe at this point. I think that would be a good choice. Adding a PCSK9 inhibitor would not be wrong. It depends on, of course, cost plays a major role, but I would agree that adding ezetimibe at this point would be the next step. So this is what we'll do. And the evidence for that I had shown you comes out of the IMPROVE-IT trial, in which benefit was really driven by the benefit seen in patients with diabetes who had an LDL cholesterol actually less than 55/46 in the trial. In addition, we have good evidence from PCSK9 inhibitor trials that we would want to lower the LDL cholesterol even further. So at this point, we would add a second lipid-lowering therapy. I think that would be a good choice. So I think this case sort of highlighted a very common scenario that we see as cardiologists, and you follow these patients as internists. The endocrinologist sees these patients if the patients are referred to the endocrinologist. And with that, I'll hand over to Dr. Chan. We have a question and answer section in a minute, but I'll hand over to Dr. Chan to go over the CKD changes in section 11.
Wonderful. Thanks, Dr. Brummer. Yes, and again, we will go over as many of the questions in the chat and the Q&A as we can at the end. So I'm just going to go briefly over the updates to chronic kidney disease in the ADA standards of care. So the who and when to screen, it's pretty simple. It's an annual screening, and that includes both eGFR and urine albumin-creatinine ratio. What do you do with the positive test results? So the important thing is that, we're really treating the early detection of CKD, especially albuminuria, as a important risk factor for kidney disease, cardiovascular disease. And so really you want to initiate evidence-based treatments as much as possible. A lot of the new trial data incorporated, these high-risk patients with albuminuria. And so that's really your biggest indicator for trying to get them on more cardioprotective and kidney protective therapies. There are patients, of course, that may have spurious results with creatinine if they have low or high muscle mass. Cystatin C is much more easily available now, so I encourage kind of more use of cystatin C whenever there's any question about the accuracy of the creatinine. Of course, you can measure GFR, but that usually requires a very specific referral center. Other things that can also qualify as chronic kidney disease is just having evidence of kidney damage. So you can't ignore that, sometimes patients have diabetes, but they have other problems. So they may end up having microscopic hematuria and proteinuria and actually have a glomerulonephritis. So that kind of summarizes most of that. When this is our what we like to call the heat map, and hopefully you're familiar with this now. So it's trying to look at kidney disease as more than just eGFR, which we know is helpful, but it's not the whole story, because we do have a lot of older patients who have mildly decreased eGFR, but are not actually at that high risk. So, the important thing is to stratify them by the albumin-creatinine ratio. We've sort of gotten rid of the microalbuminuria terminology. So we just say, moderately increased or severely increased, and, nephrologists, we like the actual numbers. So that's more helpful than using the labels. And of course, if you have the more albuminuria you have, the higher cardiovascular and kidney risk you have. And the important thing to note is that even when you have pretty normal kidney function, but you do have severe albuminuria, you're still at markedly elevated risk of all these complications. So, if there's ever any questions, you probably should. We're happy to, receive referrals even earlier on to assist as much as we can and to rule out any other causes of kidney disease. In terms of treatment, these are all pretty basic things that, optimize the glucose control, the blood pressure control. None of that has really changed. And for CKD in general, we've been sort of sticking to the lower blood pressure target, less than 130/80. In non-pregnant people with diabetes and hypertension, this is not a change. ACE or ARB is recommended if they have moderately increased albuminuria or or severely increased albuminuria. Now, in the specific setting of somebody who has diabetes but normal albuminuria, or they don't have albuminuria, there isn't any evidence that treating them with the ACE or an ARB will prevent the development of albuminuria. So it's not necessarily recommended as primary prevention. Of course, if they have cardiovascular disease or they just have hypertension in general, ACEs and ARBs are excellent blood pressure medications to use in these patients anyways. And then just a reminder to make sure that you monitor creatinine and potassium levels. Many of these drugs will have risk of hyperkalemia. Then, of course, if they're on other medications like diuretics, they're at risk of hypokalemia. And then, the creatinine bump is something that commonly occurs. So, if it's a small bump in the creatinine, I actually appreciate that the patient is taking the medication. So, you just want to make sure that that they don't also have accompanying hypotension and volume depletion and something else going on. But if the creatinine goes up a little bit after initiating RAS inhibitors, that's perfectly fine. Just monitor the patient. If the patients have type 2 diabetes and diabetic kidney disease, the updated guideline says to use an SGLT2 inhibitor to slow the progression of CKD and reduce cardiovascular risk if they have EGFR greater than or equal to 20 and ACR greater than or equal to 200. And that's an interesting change with the specific numbers there. But basically, it seems like there's been so many clinical trials of SGLT2 inhibitors now showing benefits in slowing CKD progression, and they have varying EGFR and ACR cutoffs of inclusion in the trials, and this is sort of summarizing the weight of the evidence that this is going to be beneficial for most patients if you're able to get them the medications. And I see all the comments in the chat about affordability of medications, which is a very important consideration. This is a slide from the KDIGO, which is the Kidney Disease Improving Global Outcomes, a global kidney organization, and the ADA. They combine to provide a recommendation specific to diabetic kidney disease. And you can see first-line therapy for diabetes and CKD is still going to be SGLT2 inhibitors plus metformin. And it says that the EGFR is greater than or equal to 30. And there is some risk of lactic acidosis at low kidney function. So there is guidelines on drug dosing as well, reducing the drug dose. If you have a patient who has frequent bouts of acute kidney injury, you may need to be more cautious about metformin. RAS inhibitors at maximum tolerated dose, that's the same as it has been. And then the thing that I think is sort of more new to me as a nephrologist is that we really should be thinking also about GLP-1 receptor agonists to help with individualizing and achieving individualized glycemic targets because of the cardiovascular benefits. And the CKD patients are at very high cardiovascular risk, so it makes a lot of sense. And then if they still have proteinuria and they're on RAS inhibitors, nonsteroidal MRIs have been studied to reduce cardiovascular and CKD progression as well. So those are now in the guidelines. The caveat there is, of course, there's going to be some higher risk of hyperkalemia. So you wouldn't want to start that drug on somebody who already has a high potassium level and would want to monitor that carefully. And then the rest, I think Dr. Broomer covered the lipid part very comprehensively to everybody. And just remembering that CVD is very common in CKD, so they're a high risk group. In terms of, let's see, this is talking about pretty much the same thing, just saying that, SGLT2 inhibitors are recommended even if somebody has less than 200 milligram per gram of ACR, so sort of the lower albuminuria range. The evidence isn't as strong, but is definitely there, and so SGLT2 inhibitors really should be a preferred therapy for CKD in general. In people with type 2 diabetes and diabetic kidney disease, and then this is talking about consider use of SGLT2 inhibitors additionally for CVD risk reduction. So mentioning that not just for the kidney disease progression risk, but also for CVD risk reduction. And then we talked about the non-steroidal MRAs, and talking also about how a reduction of albuminuria is itself an important target. When I'm talking to patients about albuminuria and they get kind of excited if their albuminuria changes, but from 200 to 250, I have to kind of remind them that it's actually like on a logarithmic scale. So we're really looking for changes that are like 30% changes or 50% changes to really understand if there seems to be a beneficial or detrimental effect of something. For people who have, for people, skip through a few here, that have diabetes and CKD, there's always a lot of debate about protein intake. The bottom line is that we don't really know, there isn't a huge amount of data in diabetes and CKD about different protein thresholds. So this is just basically saying not to do a very low protein diet in this population. For patients on dialysis, they often need more protein because of the protein energy wasting that occurs at the catabolic process of dialysis. Patients should be referred to nephrology if there is increasing albuminuria, decreasing eGFR. Certainly, if there's any other concerns about electrolyte, hyperkalemia, we love to see patients and help with that. And those are tricky situations. I think this has been alluded to by a lot of people in the chat. I mean, you can see the green is the beneficial things and the red is the adverse things, and SGLT2 inhibitors and GLP receptor agonists certainly have lots and lots of benefits on CKD, ASCVD, heart failure, glucose lowering efficacy, hypoglycemia risk is low, and that's important for CKD because they are at higher risk of hypoglycemia. Weight loss effects, most of our patients have obesity. The biggest downside is the cost. So, I think that's just something that we're all dealing with, trying to figure out how to help our patients. You can see a lot of the opposite effects, for the hypoglycemia risk and the weight effects, insulin, sulfonylureas. Again, those are common problems that we're dealing with that I think, as much as we can ship to those medications as possible is helpful. And then we talked about reasons for referral. Okay, so just one question, and then we'll have some time for a response. A 55-year-old patient with diabetes, eGFR is 50, albuminuria 380. Seen in clinic for follow-up, they're already taking metformin, lisinopril, empagliflozin. At follow-up, the potassium is 5.6, bicarb is 24, eGFR, I guess it had dipped down to 35, which is not accurate with the question, I'm sorry. Blood pressure is 136/82. What would you do next? One, start on a potassium binding medication, start on hydrochlorothiazide, 25 milligrams a day, decrease the lisinopril dose by 1/2, discuss reducing potassium in the diet. Okay, and this is, I try to make it a tough question because these are all things that you might consider doing, and none of them would be totally wrong by any means. So it seems pretty split for most of the answers. So the way that I look at this type of a patient is that, really we want to try to minimize cardiovascular risk as much as possible and kidney risk. If blood pressure is a touch high, there is a little bit of mild hyperkalemia. They're already on ACE inhibitor and empagliflozin. we really try not to reduce ACE inhibitors if we can help it, because we know that that's really going to have the longest lasting benefit, even if you're dealing with mild hyperkalemia. So in my view, you would want to start this patient on a thiazide diuretic to help with the blood pressure, help with lowering the potassium, and of course, we're going to do some home blood pressure monitoring, as I mentioned, as this is a very high risk patient, to make sure and follow up their labs in a couple of weeks. Wonderful. I think I'll leave this slide on here, and then we can open it up to the discussion. But this is just the slide from the KDIGO working group, just discussing hyperkalemia in this setting. Make sure you review concurrent drugs. Moderate potassium intake is always important. To then consider diuretics, sodium bicarbonate, or potassium binders, depending on the situation. And then if that doesn't work, then reduce the dose or stop ACE or ARB.
All right, thank you very much, Dr. Chen, for outlining the CKD section. So I think at this point we'll open the forum for questions. I tried to answer a couple of questions online already here. There were good points, good comments. Lots of questions about costs and formulary, and how do formularies change when patients are required to get, for example, metformin as first-line therapy, which is a great drug for A1C reduction. So we would hope that payers adapt to evidence, for cardiovascular benefit, as well as according to changes in guidelines. So.
Yeah, I think those are great questions, because the payers are often the ones that are unfortunately determining therapies, and so I guess I wanted to clarify that, Dr. Breumer. So I guess the number one question is metformin first line, yes or no in general, and then in the context of cardiovascular disease?
Yes, I mean, if you look at the pharmacological approach and the algorithm that is in the guideline, in a patient with atherosclerotic cardiovascular disease, CKD, or heart failure, metformin would not be first-line therapy.
That's about as clear as can be. Thank you, Dr. Breumer.
Yes, there was an important question about the LDL cholesterol goal from ACC. American College of Cardiology would state the LDL cholesterol goal would be less than 70 in a patient with recent myocardial infarction. That may apply to some patients, but if you actually look at updated cardiology guidelines, for example, I mentioned the ESC, European Society of Cardiology, as well as the guidelines now for a patient with diabetes. Keep in mind, patients with diabetes are at much higher risk for future events than a patient without diabetes. So the LDL cholesterol goal would be different. So American Association of Clinical Endocrinologists, as well as European Society of Cardiology, as well as ADA, now endorsed by ACC and AHA, would recommend less than 55 for this patient.
So I see a couple other questions. Let's see. So one of them is mentioning that 75% of the patients in trials with SGLT2 inhibitors and GLP-1 receptor antagonists were on metformin. Does this imply we have inadequate data to know if we should be including metformin for these patients? So that's a great question, and I don't have the answer, but I'm curious to know how the guideline committee sort of thought about that, because we can't really go back and do trials of incorporating metformin or not, because it's very difficult. It's sort of embedded in clinical care.
Yeah, I think, again, I think this is an important notion. I do think the evidence is limited, as indicated in the guidelines, to support the combined treatment, but there are, there are sub-analysis, meta-analysis, which suggests that benefit occurs independent of whether a patient is on metformin or not. But I think, certainly an outcome trial to show patients plus minus metformin would be ideal, but I doubt we would have that or get that. So.
And a good point about, what does lifestyle change mean? So, yeah, I totally agree with the commenter, Andrea Troutner. So, referral to a registered dietitian is very important for the treatment of patients with diabetes. Certainly, if they have kidney disease, I mean, there's so many things that are quite complicated that they could really benefit on individualized advice and evaluation from a medical nutrition therapy. There's also a question about where, finerenone, which we did mention in the presentation as being recommended for these patients with diabetes and proteinuria. Where do we start finerenone in the decision-making tree? Kind of the same problem. I mean, these trials are going on alongside SGLT2 inhibitor trials. So, and of course, all of these are newer, more expensive medications. So I don't know that we can say for sure. I mean, my personal perspective is that the SGLT2 inhibitors have probably the biggest amount of evidence in that setting. So I would sort of prefer getting patients on those medications first that need it, and then if we're still feeling like we need the finerenone. But I don't think it's directly mentioned exactly, since we don't have that type of a trial design.
So I think one additional question that we are faced quite frequently is, of course, when these newer medications are cost prohibitive or not on formulary. Dr. Cheng, what do you think about sulfonylureas in patients with CKD?
Oh, yeah, I mean, right. So sulfonylureas, you're right. I mean, a lot of times there are patients that they can't afford the other medications. So really you want to avoid the glyburide. Glipizide is fine. There are some very nice renal dosing recommendations for all of the drug classes and different medications within each class in that KDIGO ADA guideline, which I'll cut and paste in the chat as well. And I see there's also an important question about eGFR. Yeah, so in terms of eGFR, we are trying to get away from this, any sort of race-based reporting. It's probably a slow process amongst different labs, but a lot of labs are using the race-free version of the equation, so that we're trying to not make decisions based off something that that can be really hard to define and is not necessarily useful in clinical care. It could cause some other problems. Wonderful. I think we're at the top of the hour, so thank you everybody for participating, and hope you guys have a good afternoon or morning or wherever you are. Thank you.
Thank you very much, Dr. Cheng, for hosting this, and thanks to the American Diabetes Association, American Heart Association for their important efforts in Know Diabetes by Heart.